Good morning, afternoon, or evening. I welcome you all to join us in the special webinar number 134, organized by the Andean Health Organization Equality Nuane Agreement. This cycle of webinars started in May 2020. This year, we are celebrating 50 years of the Andean Health Organization Equality Nuane Agreement, a very sensitive and significant anniversary due to the difficult time we're going through. However, as a reference in health in the region, we continue uninterruptedly the joint and coordinated actions with the 6 member countries, Bolivia, Colombia, Chile, Ecuador, Peru, and Venezuela, thus fulfilling the goals and objectives to strengthen the health of our. As a reference in health, we highlight the following. Vaccination against COVID-19 is safe and effective to protect ourselves and others. The more people who are immunized, the less likely they are to become infected. Make sure that you and your families receive the second, third, or fourth dose. There is no excuse for not complying with the COVID-19 vaccination. The socioeconomic and environmental context in Latin America and the Caribbean establishes a scenario in which hunger, food insecurity, and malnutrition have increased. Political decisions are required to achieve sustainable, sufficient, inclusive, and efficient agri-food systems that generate equal access to a healthy diet for all. Climate change threatens life, health, and well-being. However, we can contribute to its preservation from wherever we are, generating social policies and a sustainable development model. By joining an initiative in defense of the environment, buying local products and plant-based foods, we can use public transportation, cycling, or walking, as well as reducing consumption by reusing, repairing, and recycling. It is everyone's duty to restore the relationship with nature. It is necessary to recognize the ancestral knowledge of the native peoples who have lived in balance with Mother Earth and practice good living. Well, in accordance to what has been said, today, Thursday, August 18, we open our virtual doors to discuss a topic of great importance for our region: COVID-19, long-lasting symptoms and sequels. We invite you to leave us your name, organization, and country from which you're joining us through the comment box on the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. To access the certificates of attendance to this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook Live or YouTube Live chat. The certificate will be sent to your email in the next few days. This webinar will be developed with the usual dynamics. We will start with institutional greeting, then the presentations from our speakers, the active pause, and the space for Q&A. To begin this important day, I give the floor to Dr. Maria Carmen Calle, Executive Secretary of the Andean Health Organization Hipólito Unanue Agreement, who will give the welcome and the institutional greeting. Go ahead, Dr. Calle. Thank you very much, Lucho. Well, good morning, good afternoon, good evening. The pandemic produced by SARS-CoV-2 in the world has so far accumulated more than 696.5 million cases and 6.4 million deaths worldwide, making it one of the most lethal pandemics in contemporary history, together with typhus, Hong Kong flu, AIDS, cholera, and the first in history caused by this type of virus. It is the pandemic that broke several health records because it was the one that was detected the fastest, the one that in which 10 days the SARS-CoV-2 genome was sequenced, the one in which 15 days later a detection test was obtained, the one that had messenger RNA vaccine within a year, and the one that spread the fastest in the world thanks to globalization and modern means of transport. In this time of more than 2 years, we have learned that this pandemic has evidence or highlighted the vulnerabilities of populations with less access to healthcare. That healthcare systems have been overwhelmed by the number of cases and initially by the lack of equipment for the care of severe cases in intensive care, intermediate care, and hospitalization units. That we are intrusive against the environment, and in response to this, more than 70% of the diseases that affect man are produced by animal diseases. That is, the pandemic generated an exhausting, excessive, but unbearable work that led health workers to reach the limit of their physical and mental capacity due to the permanent stress to which they were subjected. In summary, the pandemic has evidence that has affected health, society, the economy expressed by the interruption of the production change worldwide, the resounding fall of tourism and the entire support network, the fall of raw material prices and the increase of public debt and recession, changing the means of life and the way of life of the population, which makes necessary a reevaluation of health as a fundamental pillar for the achievement of the Sustainable Development Objectives or goal. In this meeting, and contributing to the knowledge of lessons learned, and we share the concern of knowing that the coronavirus not only affects the respiratory system, but also the nervous, cardiac, renal, and endocrinological systems, affecting people who have had COVID-19, but in a group not less important, a persistence of symptoms and signs has been identified after the respiratory crisis has passed. The patients at 4 weeks persisted in different proportions with headache, myalgia, loss of smell, taste, joint pain, memory and concentration impairment, fatigue, and dyspnea. And many studies have been and continue to be carried out around the world on this syndrome. And that is why in this opportunity we have invited international experts to share their knowledge on the latest advantage that have achieved in their specialties and in their countries. We are grateful for the presence of Dr. Eduardo Penny from Cayetano Heredia Peruvian University, Dr. Esteban Ortiz Prado from the Central University of Ecuador, and Dr. Luis Jorge Hernandez from the University of the Andes in Colombia, who will share their experiences of prolonged COVID and its sequelae. Welcome all. Thank you, Dr. María del Carmen Calle. After the greeting of our Executive Secretary, I introduce myself. My name is Luis Bengolea More, epidemiologist, coordinator of border health and thematic areas in the Andean Health Organization, and I am pleased to be in charge of moderating this seminar. What is long COVID or prolonged COVID? Is it really frequent? When a person is discharged and remains with symptoms, can it be said that she has long COVID? What is a sequelae? It's part of the acute post-COVID. To answer these and other questions about this syndrome, we will have with us professional experts from prestigious universities already introduced by Dr. Calle. At this moment, we begin with the presentation of Dr. Eduardo Penny Montenegro. Dr. Eduardo studied medicine at the National University of San Marcos in Peru and the specialty of internal medicine at the Peruvian University Cayetano Heredia in Peru. He completed tropical medicine at the University of Sao Paulo, Brazil, and a master's degree in medicine, and is especially in geriatrics by Cayetano Heredia Peruvian University. He's an associate professor and member of the advisory council of the medical school at Cayetano Heredia. He's an honorary member of several national and foreign medical societies. He was president of the Peruvian Society of Internal Medicine and president of the Latin America Society of Internal Medicine, SOLAMI. He is Masters of the American College of Physicians and Fellow of the American Geriatric Society, tutor of the Argentine Society of Medicine. He received the Gold Medal of Merit by the Medical College of Peru and the Gold Medal from the same institution, Andean Regional Coordinator by the FIMI, and received recognition for the Internist Day in 2020. He is an associate member of the National Academy of Medicine and currently works at the Delgado Clinic. He is an active lecturer in several national and international scientific events. Has presented and published several scientific papers. Welcome, dear Dr. Penny. The floor is yours. Thank you, Luis, for your kind introduction. We're going to share the screen. Let me see.
¿Está compartida? ¿La ven?
Yes.
Okay.
Well, first of all, I'm thanks for this kind invitation to discuss about something that is extremely important. Dr. Kai already mentioned that we agree with the Hopkins Observatory with more than 600 million cases of those that have been proven to be infected, but perhaps this figure is much, much higher worldwide, and with a mortality of more than 1%, and in some countries up to more than 5%, which is extremely concerning. This is something important for me, where I'm going to focus my presentation, and we're going to discuss it. When one has COVID, it may have a full recovery. Unfortunately, not always that recovery is necessary, a complete return to a complete health status, and the resolution of these symptoms of the harm may last, and we consider, in order to talk about long COVID, more than 4 weeks, or some injury that could stay permanently in time. I would like to remind you that this pandemic is in its 3rd year, and we are seeing cases of this problem up to now, today, when they start at the beginning, and we don't know if this is going to stay permanently throughout their lives. and it's going to vary depending on the frequency of each country, depending on the type of virus. And this is very important because we know the behavior of the different variants of the virus. Not the same to compare alpha, delta with Omicron. So much of these, many of the sequences and sequelae that can be presented may be quite different among them. Something very important is that it affects all ages. This unfortunately was focused on the idea that this occurred in people mean age or the elderly, because in the elderly where you see the more morbidity, and did not consider the small ones because it was thought that it was not important, something that we see that that is not the case. So we need to take into consideration that this can present in any type of person, regardless of the age, sex, cultural level, race, etc. This is a real pandemic, and as such, it has to be considered and not only ends with recovering from the acute state, but there are problems afterward. Many have asked themselves if long COVID really exists or not. And although there are a number of recovery models, there's a significant number of patients who have stayed with persistent symptoms. And here we have a problem, because of what we have seen is that between 10 and 20%, but some series show 25 or up to 30% in other series, the persistence of these complications. Another problem that we have is the definition of what we are talking as a long COVID. Let's see how each one actually has its own definition, and this may change the numbers. There is many people that they think that this is a psychosomatic problem. Some others think it's real, but the evidence is in favor of demonstrating that this is a real problem with systemic involvement. And in this case, we have found the presence of virus in more than 50% of the patients who have long COVID. And that is telling us that that's real. Much of the symptoms are related to muscle weakness, cognitive impairment, the post-UCI syndrome, which also present this post-traumatic stress disorder that may be confused with a post-COVID because of the post-traumatic stress disorder. This may present as persistent symptoms in those who have suffered severe COVID. They stay with those symptoms, or no symptoms can appear in patients who were asymptomatic and that perhaps they start showing a disease. And in the history, we learned that they had COVID, either clinical COVID in the cases that were mildly symptomatic, or also in patients who didn't have symptoms, but they were antibodies show that they presented something. The most usual symptoms are fatigue, dyspnea, joint pain, thoracic pain, and some cognitive impairments, sleep disorders, and most of them usually symptoms go away by themselves or with symptomatic relief, and it's a structured program of physical activity. Some definitions that are important to have in mind: acute COVID, they said in the first 4 weeks, and the long or persistent COVID is a multi-organic symptomatic complex that affects patients who have suffered COVID with confirmed diagnosis by lab tests or without the diagnosis. And this also leads to confusion, and that they stay with that symptomatology after 4 weeks. And as we said, the prevalence can vary. When we talk about post-COVID sequelae, these are symptoms follow the structural harm of the complications suffered and usually more frequency in patients who had severe forms, including those who were admitted to the ICU. For example, in the respiratory issue, they present a secondary pulmonary fibrosis. One of the conditions that we recently been called, trying to put some order, is the so-called persistent post-COVID or post-COVID conditions, or PCC, with the direct and indirect effects of the virus. In another denomination, it's called the long COVID, that may affect organs and systems and manifest as new diseases. And this is quite a challenge. We're seeing that after COVID, they're becoming ill because they were increasing the prevalence of heart disease, diabetes mellitus, renal, neurological, hematological, and mental diseases, where there's a common denominator that is the having COVID. And not only that, but there may be a worsening of those who already have these type of conditions. So be careful. It's not just symptoms, but it's the start of new diseases. And the other group is called the post-acute sequelae by SARS-CoV-2 infection, PASC, where we only see the direct effects. These are new definitions in order to put some order. The World Health Organization in 2021 issued their own definition of post-COVID, defined as a condition that occurs in an individual with a confirmed or probable history of infection by SARS-CoV-2, usually 3 months after the start of COVID, with symptoms that last at least 2 months and cannot be explained by an alternative diagnosis. So you rule out any type of disease or condition. But there's a combination of problems. The common symptoms that are described are more than 200, but are mainly around 60. But there are more than 200 symptoms that have been described, which makes it all very complex. And the most common symptoms include fatigue, dyspnea, cognitive impairment that may alter the daily life of persons. And this is one of the concerns of all the ministries of health throughout the world and in all countries in general. As I mentioned, this can be of new onset or following the recovery of the acute episode, or persist from the beginning. And they may also fluctuate or relapse in time. And we always discuss about having a new definition for children. And unfortunately, there are no diagnostic tests for this post-COVID state. In asthma, they found antibodies that persist in 50%, and in different situations, even urine and feces. But in plasma, it can be up to 50%. And this is interesting because it opens the possibility of an antiviral treatment for this type of patient with persistent disease. The CDC has also established their definition, and they state that some patients may have symptoms that last weeks or months after recovery, even in people who have not been hospitalized or who had a mild disease, and they can present persistence of symptoms. So here's an important concept, because in those persons who had mild COVID or asymptomatic COVID, that are sometimes difficult to diagnose unless you're doing some research. But when the disease is over, forget about it. This condition is over. But you need to pay attention that in some of these patients, they're going to show new symptoms in time, and we're talking about a serious problem that's going to impair their general state of health. The NICE guidelines also have their own definition: acute COVID within 4 weeks, symptomatic COVID-19 between 4 and 12 weeks, and after 12 weeks, after the third month, they call it post-COVID-19 syndrome. So as you can see, this is somewhat repetitive, but it's important that we also know that there's different definitions. This is an interesting study published by the meta-analysis of 57 studies with more than 250 COVID-19 survival. This is a meta-analysis, and more than half of the patients with COVID suffered sequelae after 6 months from their recovery. I initially mentioned 10-20%, being up to 30%. But this study means that 54%, more than half of the patients who suffered from COVID, had symptoms 6 months after their theoretical recovery. The mean age of these patients was 54.4 years, 56% were male, and 80% of them were hospitalized in the acute phase. The most common were decrease in functional motility, lung abnormalities, and mental health disorders. And it's interesting because, according to them, this is going to have a high scale in low, medium income countries. However, in another study that has been published, they find that in high income countries, it is 54%, and mid or low income is 56%. So we're talking about the same figures in patients that come from high income compared to those on mid or low income levels. This is an analysis, meta-analysis of 2,100 studies, and you see that more than 50% of these patients with symptoms after 6 months, with 3 defined groups with involvement of organs and systems, constitutional symptoms, and functional motility issues, as it was cataloged in 3 defined subgroups. This is interesting. This is a recently published study in The Lancet. It's a Dutch study that started in March of 2020 to August of 2021. But you need to consider that at that time, the major problem of viruses that we had were the Delta variant, even Gamma variant. So we need to look at this very carefully, but because these figures may not be extrapolated now that we have Omicron, and we will going to learn about that in the coming months. Patients underwent periodical evaluations, and this is the interesting part of the study. The persistent symptoms were present between 90 and 150 days post-COVID, and they controlled patients with COVID, but they also selected a group of non-COVID controls. The frequency of symptoms was 21.4 in patients with COVID-19 and 9% approximately to the non-COVID. So they say that the difference, which is 12.7%, can be attributed to COVID. Because in those controls, they had symptoms in patients who did not have COVID. We have to subtract that from those who really had COVID. So the number for them is 12.7%. And the persistent somatic symptoms were thoracic pain, dyspnea, pain at breathing, muscle pain. Myalgia is an important symptom, a joint ageusia, anosmia, and they also describe extreme paresthesias in the extremities. And this is important because then we've seen a study where there are problems of neuropathy and myopathy in high numbers. Also, this patient complained of a sensation of a knot in the throat and a symptom of alternating heat and cold, especially in lower limbs, as cold is feels hot, and this has been not considered important, but they have detected it in a significant frequency. Now, what are the severe consequences of the post-COVID syndrome? We have sarcopenia, with a decrease in muscle mass and strength, sometimes related to physical inactivity and others related to the disease itself, multi-organic failure, frailty, vulnerability, more frequent in the elderly, capacity and dependence, chronic anxiety and depression, and in some studies has demonstrated that it lasts 6 months and then disappears. That malnutrition, due to the dysgeusia and anosmia that they present and social problems that come together with this malnutrition, cognitive impairment, because many times this is related to the capacity anosmia and the institutionalization that these patients have to undergo because they cannot work on their own. All these are symptoms that I mentioned of those 200 that has been described. I'm not going to read that to review the entire medicine. And this is interesting. What are the proposed mechanisms? First place, they are not completely understood or proven. It is thought that in many cases it may be a direct effect of the viral infection. Why? Because there's a persistent viremia due to an immune fatigue. The immunology is exhausted, and we demonstrate that more than 50% of them have a persistence of the virus and relapse or reinfection. And we see that people who have 3, 4, 5 COVID with different variants. Then we also, it may be due to inflammation or an immune hyperinflammatory response or autoimmunity, also tissue injury generated by cytokines or hypoxia, the coagulation and vasculopathy disorders in moderate to severe cases, prevalence of autonomic and or neurological dysfunction, or metabolic and endocrinological. And you also have this bacteriosis for patients who their intestinal flora is impaired, and some of them have improved by receiving probiotics or this type of substance, but others don't. So always some doubt, and also a poor adaptation of the angiotensin converting enzyme pathway. The indirect effect may be done by the post-traumatic stress disorder, social isolation, economic factors, and the family repercussion. These not only medical problems, but also there's a number of social and economic effects. It's a study that I mentioned in this cohort of patients with COVID-19 and persistent symptoms. 45% of them had detectable plasmatic levels of the RNA of SARS-CoV-2. So there was a systemic viral persistence. 51% were positive for our RT-PCR in plasma, urine, or feces. And as I mentioned, this generated a possibility of an antiviral treatment in this state. I'm not talking in the acute forms. This is a persistent COVID. We also have the lung manifestations that one of the presenters is going to talk about this, but it's important to keep them in mind. And there are also cardiac, skin, nasal, auditory problems. The pulmonary fibrosis, this is one of the most serious complications because these are patients that are going to have in respiratory failure, perhaps in a progressive manner where there's a number of histological changes. We also have the cardiac complications that are frequent, including in those asymptomatics, and this sometimes has been detected by chance. Patients who are evaluated by any other reason, they discover that they have problem issues we didn't have before. Myocardial injury, young myocarditis that sometimes have presented as an arrhythmia or coronary ischemic disease or exacerbation of cardiac pathologies that may get up to cardiac failure. And there are a number of hypotheses for the neurological manifestations, where one of the important ones are the microvascular hypothesis, where there's involvement with vasculitis, with the cytokines, peripheral disorders, the presence of pro-inflammatory cytokines that may stay for a long time in the circulation. They have proposed some drugs but to be honest, none of them are effective. How can we deal, or how do you deal with this problem? First thing that you should do is set up a multidisciplinary team. This team has the goal of to the follow-up and management of patients with prolonged symptoms and sequelae by COVID-19. And this is something that is very important. I would like to tell you. When you speak about a post, there always has to be a good evaluation at the beginning. So in all of these type of patients, you should have a history with all the parameters to do a follow-up to all patients in general, not only patients with post-COVID, all patients who have acute COVID, and then on follow-up, as it should be done on these patients, have this history as baseline and see what things appear and what disappear. And with that, we're going to prevent perhaps adequate lack of follow-up of words with complaints are real and those are not, and what of those are related to non-COVID. And to have a control group of non-COVID, that's the only way to do an adequate research to learn about this problem. In this team, you need to have general practitioners or internists, lung specialists, cardiologists, neurologists, psychiatrists, including psychologists, and also physical therapy, mental therapy, occupational therapy, language therapy, and also nutritional therapy, because we think that nutrition is one of the problems. So this is a multidisciplinary team that the institution should set up so that when they have a patient with acute COVID and follow them until all the problems disappear. That's the only way to learn about the truth, if it exists. So take home messages. This is a summary of what I told you. We don't know exactly what we are talking in relation to duration. That is usually one of the definitions that is mostly being used in the persistence of systems beyond 4 to 12 weeks. And you see, this is a wide range of 4 to 12 weeks. In patients who don't have a cure period after the acute disease, it's not exclusive of patients with severe disease. This is extremely important to keep in mind. Consider that asymptomatic patients or patients with a mild or moderate disease may present this type of problems. In those asymptomatics, they show symptoms in the following months. Frequent symptoms are fatigue, dyspnea, cognitive disorders, sleep disorders are very frequent. The presentation that is independent to the acute severity, with asking structural damage, and the answer is yes, in some cases like we see in the lungs or the heart. Long-term effects in different systems. These conditions, the symptoms can fluctuate and they have exacerbations. It is important trying to rule out other processes that may explain those symptoms to avoid confusions. This can present in all the age and racial groups. The management has to be holistic, is symptomatic, with rehabilitation and multidisciplinary. There are studies that demonstrate that hyperbaric oxygen therapy may help a group of them. It is important how to provide probiotics may help another group of them. And it's also interesting the treatment with vaccination. It has been seen that there is a group of patients that having COVID, every time they receive the vaccination dose, they improve. And this is interesting because this makes that we put pressure on the population, to the entire population. They vaccinate in the required doses in following the schedule. And this is extremely important. And remember, that if someone doesn't want to have a post-COVID, the best way or the only way is by not having COVID. And to avoid COVID, the best way to protect ourselves are still the measures as vaccination,
el uso de la
the use
mascarilla,
of
el lavado
face
con
mask,
agua y
hand washing
jabón de las
with
manos,
water and soap.
los clásicos,
These are
evitar
the classic
los
ones.
grupos
Avoid
cerrados
being
y
in
evitar
closed
contactos.
environments and take
Esto
care.
es una realidad
So
y
this is our reality.
post-COVID,
This post-COVID or
lamentablemente,
long COVID
no lo vamos
exists,
a
and
poder ver. No
unfortunately,
sabemos cuál va a ser la
we don't
duración
know
en todos los
how
casos.
long this is going to last in every case.
Pueden haber
So far, we know
consecuencias
that there can be
severas,
persistence of up to
pero no
3 years in
pero no
those who were
sabemos
acute,
cuál va a
but
ser
we
el
don't know
futuro de esta
what's going to
situación.
be the future of
La
these
otra cosa a
patients.
tener en cuenta
And
es
the
que
other thing to
muchos de
consider
estos
is
conceptos
that
pueden
all these
cambiar
concepts
porque
may
estamos
change
frente a nuevas
because we
variedades,
are having new
variedades más
variants,
contagiosas
more
con menos
contagious,
letalidad.
but with less lethality.
Y muchas gracias por la
And thank you very much for
atención.
your patience of listening to me. Thank you, Dr. Eduardo Penny, for your excellent presentation. We can summarize in some critical aspects that are important that you have mentioned quite clearly. In first place, it is important to indicate that in the world, there is not, we don't have a definition of the long COVID. There are different institutions that have tried to come down up with a definition, but most of them coincide that there are different types of severity in the definition of this process. It is also important to indicate that the impact of the disease on the person may be variable, and it many times depends on the viral variant that has affected that individual. The severe forms not necessarily are those who end up in the long COVID. And many times this presents in asymptomatic and people who have mild forms of the disease. Man is more affected in several studies, and the sequelae affect more women. And another important aspect highlight is that there is a consequence that may be present in at the acute form and some other times with the immune response. And thirdly, it may be related to the results or the consequences of this immune response. We need to work with a multidisciplinary team in order to improve that person, and that the vaccine is an excellent way to decrease the symptoms and the final outcomes of this long COVID. Thank you very much, Dr. Penny. We invite you to stay in the room for we can go to the Q&A session at the end. Now, we would like to extend a warm welcome to Dr. Esteban Ortiz Prado. Dr. Ortiz Prado has a PhD in medicine and surgery from the Central University of Ecuador, a master's degree in mountain medicine and high altitude physiology, master's degree in public health and global health from the University of Southampton in the UK, and a PhD in biomedicine from the University of Barcelona. He has been part of the scientific advisory group of the Ministry of Health of Ecuador during the COVID-19 pandemic, and is currently the principal investigator of One Health at the University of the Americas in Ecuador. He has participated in several research projects and has a significant number of papers related to COVID-19 in Ecuador. Welcome, Dr. Esteban Ortiz Prado. You have the floor. Thank you, my dear Dr. Bengolea. It's a pleasure to share with you this panel with extraordinary experts. Well, I'm going to share my presentation, and I would like just confirm that you can see it. I am going to talk about long COVID in Ecuador. Dr. Penny has been very clear of what long COVID is, the current evidence. He has made a journey from when we start talking about this disease or this sequelae of a disease to what we are experiencing now. And there are certain aspects that are still not clear. People don't know how to define it adequately, long COVID, post-COVID, post-acute, etc., etc. So in that logic, we have brought you this topic that talks about long COVID. We have dedicated most of these last years to study this pandemic. I returned from my master's degree in global health precisely before the pandemic started in November of 2019. And we spoke about the pandemics before returning, and that is why we've taken a very personal role in studying COVID-19 in Ecuador and in we have contribution to the world. We have finished the first epidemiological study of COVID-19 and the sequelae of COVID-19 in Ecuador. We think that this may be one of the first in this South American continent, and these are the results. To put this in context, we have analyzed, and it's amazing how we live this pandemic in real time. Those of us who have dedicated our lives, professional lives, to research. But from the start of the pandemic, we had to describe a little we know. So we did a very interesting paper that's the most quoted in this journal, reviewing SARS-CoV-2, what's the virus, how it affects the cells. Then we focus on describing COVID in Ecuador. And so far, we have published more than 40 papers related to COVID only during the pandemic because we have dedicated most of our time. And to give you a context, we have spoken at the beginning, Maria Carmen mentioned the COVID waves in Ecuador, in South America, and in the Andean countries. We had a marked deficiency in terms of diagnosis. Many of the tests were not carried out. The few ones that were done were not registered. So we had to explore the excess of deaths as an approximate marker of the incidence and, of course, the mortality by COVID-19. So here you see an interesting graph on the excess deaths in Ecuador. That, for me, can be an interesting proxy of what the COVID-19 waves were in Ecuador. Here we need to mention that Guayaquil, as you can recall, in Ecuador in general, we have a title that is not an honor, that is the country with more deaths by COVID-19 in the world, per capita deaths in the shortest period of time. We know that Peru, in the large numbers, shows an abundant excess in deaths and is the country with the highest death excess has reported with regard to this pandemic. But Peru had, and correct me if I'm wrong, had something less than 700 deaths in one single day by COVID-19. Brazil had something more than 4,000 deaths in one day. The US had more than 5,000 deaths per day in one single day. But Ecuador had more than 1,200 deaths per COVID in one day. It means that in the per capita, we have 700% more deaths from COVID than the US. We had a per capita rate greater than any other country. So there are several causes, but the data are clear. Perhaps we have sent this long COVID paper for review on the journal. It will be available as a pre-publication because we sent it yesterday. It took us a long time to finish the analysis because, as Dr. Penny mentioned, there's so much information and data are self-reported that this was our proposal. So what we propose, these are the background of long COVID. I apologize for it's in English because I, this is from a previous presentation. I'm not going to talk about the background because it's been extremely well presented before, but what were the objectives of our study? Which is basically to describe for Ecuador what happens with the COVID sequelae. You must remember and you must understand that in our country the data are quite efficient. We trust in hospital discharges or death indexes of our systems of national statistics, but data recollection of prospective data and retrospective data is quite complex because we don't have digital clinical records. So we need to trust the most simple research, which is ask people. It's basically to do an observational descriptive study and evaluate from the information point of view, what are people telling us? And here I fully agree with Dr. Penny. This is not the adequate way of doing a study that would allow us causality. But as I always mention, there's nothing worse than not having anything. So we have information and we would like to describe the long COVID. Now, due to strategic reasons from the publication point of view and make it more attractive for the international public, we did an analysis that allowed Andean countries, Colombia, Peru, Ecuador. We are very rich in geographical diversity and we have altitude on our side. You will say, well, but you also say that on Tibet and the mountain ranges, and the Rockies in North America, in Ethiopia, there's high lands, but in the Himalayas, they don't have sea level. So living in our countries offers a wide range. So we included this additional analysis because this will be the topic of a future webinar because we have also studied COVID in the high altitude. And not to go into that topic, the altitudes must seems to be associated to more demographic differences than geographical differences. And then what did we do? We designed a questionnaire of self-reporting. The people who suffered the symptoms reported them. We did a massive launch of the information. We use social networks to disseminate this type of instrument. And I'm sure that no one had the story of where I've been working in Ecuador, but I was lucky to I was able to spread this in massive media like national TV. So we occupy those spaces to talk about these surveys through a QR code. So people who take a picture to that QR code that was shown in national TV, and that allows you to have a quick national-wide expansion. We did a sample calculation based on the Ecuadorian population to have an idea of how many people we needed to at least have some representative result that is provided by a study of this kind. This is the data management. We have 2,270 answer surveys. We stay with 2,100 because we did a complete analysis, response by response. You should remember that when you're in social networks, sometimes you don't want to complete a questionnaire because you become lazy, you get tired, or they don't close the survey adequately. Or there's people that like to put erroneous answers. So we did that data cleaning and we had some interesting results. First of all, that's in Ecuador, most of them are mestizos, that is clear. And I'm sure many of you have observations to the limitations. Well, first limitation, why mestizos had more response than the indigenous people. That's due to access they all because of if they have a cellular phone or TV. But most of them were mestizo. There were higher response from women. Why women respond more? There's several explanations because they're most aware of their own health condition, or perhaps men sometimes with that aspect that now I feel fine, I'm okay, they would not respond to this survey. But these are the results that we obtained, and we may discuss them later. Also, most of these people live within the high lines, Quito, the capital city, so we have a large number of responses in high altitude, but then we control, afterward we control for that. Now going into comorbidities, we found something interesting. People who responded, 22.5% have other comorbidities, most common hypertension and overweight. But you must understand that out of these 2,000 people, we were able to collect more than 7,746 events. People had 2, 3, or 4 symptoms. That's why we have much more symptoms than people. Just to clarify, in general terms, what we found is what people most reported was fatigue up to 8%, hair loss, and difficulty concentrating. So with that logic, we did age group analysis. We found that statistical significance between adolescents and youth with young adults and in the elderly. In general, the long COVID goes together to what Dr. Penny mentioned is basically affects all the age groups. Perhaps in this study, we had a sample that was mostly with young adults. And once again, this is one of the limitations that because we got them through social networks and digital platforms, the elderly population or the youngest perhaps didn't have access to this, and this is described among the limitations. What do we found in terms of vaccines? Something interesting. First thing is that patients who had COVID before receiving the vaccine, because remember that we have many patients who had COVID with their complete schedule or incomplete schedule. Those who did not receive the vaccine before they came down with COVID were 53% more symptoms. So the vaccination has a protective effects in general terms for long COVID. On the other hand, it was interesting to see that before the vaccines, hair loss was reported, loss of smell, and ageusia that lasted long. But people who had COVID with their complete vaccination schedule, the symptom that really bothered them most was persistent cough. And I did this analysis. Why the weight loss, the anosmia, and ageusia last much longer with a long COVID. In terms of before the vaccination, there are several hypotheses. The most simple one is less virulent variants, but remember that SARS-CoV-2 is quite neurotropic. It affects nerves, and it may be that the vaccine reduce the severity, which is, as we know, as an effect of vaccines, reduces the severity of the condition. And there's an interesting finding. This is a table that we found in general terms. There are no marked differences in terms of sex, besides that women reported more and women have more long COVID, quote unquote. I don't know if women have more long COVID or it is that they report more long COVID. And the most significant difference was hair loss. Women reported much more hair loss. So I don't know, in men, we can say that my hair is falling, but perhaps it's because I'm man and it's a normal situation as opposed to women. That was one of the things. The ageusia was more marked, and the anxiety and the self-perception impairment were greater in women. Now, in terms of what we found in the high altitude, you can see that there are several things that we have found in high altitude in different research projects. One, that there's a lower mortality in high altitude in terms of crude epidemiology. People die less by COVID-19, not because they live in a high altitude, and it's more due to the population density and other factors. Other thing that we found in cross-sectional study adequately controlled of some intensive care units in Quito and Guayaquil as a good control. We found that by living in high altitude was associated to a better survival in severe COVID. Why? Because we live in chronic hypoxia and our lungs and we are more adapted to deal with lower levels of saturation and perhaps that chronic hypoxia, generate more angiogenesis, better lung capacity, and we have better survival. That has been demonstrated in a well-controlled study. Now, in terms of high altitude and long COVID, we found that people in high altitudes have somewhat different manifestations. For example, tachycardia or a decrease in libido, insomnia, and other characteristics that were found in high altitude. Another thing that we know exactly how to explain it yet, that in high altitude people report the persistence of symptoms with more earlier than there's an early onset report of symptoms, and with some statistics that provide support is by living in high altitude. If you develop COVID and if you develop long COVID, you have a higher risk of having symptoms that last more than 1 year. We have found people that were still complaining that after 1 year, they still have complaints. Remember that this is self-perception. This is a survey completed by the patients themselves, but it was a surprise that many people that live at lower altitude have symptoms that didn't last too long. And why do symptoms last longer in high altitude? Well, there are many reasons that we can discuss. You see the graphs with these significant differences in certain population groups with a number of long COVID. We found, for example, the number of symptoms, but at the end we saw that high altitude has an effect in relation with the duration and quick representation, early onset of the complications. In terms of risk, the good thing of living in the digital era is that before completing the analysis, we saw a publication that mentioned that the risk at the beginning of the pandemic, this is just a simple cold, and we were going to come down with it. People said, well, let's better get it now. But in addition, that when we know that long COVID is presented in asymptomatics, in a mild COVID or severe COVID, and it's basically present if you had COVID or not, we see that we found that there's an increased risk of developing long COVID in people who have more than one infection. The fact that I came down with COVID twice puts me at a higher risk of developing long COVID. Completely opposite to the belief that said, if I get COVID today, perhaps I'm going to have better way immunological capacity to fight against the disease. Perhaps that's true. Your immunological system have more tools to fight against the virus. But in terms of long COVID, it seems that more than one infection is associated to a risk of almost 29% of having more long COVID than the control group. And of course, the issue of developing very long COVID is one of the things, the deficiency that we have information that lasts more than 12 months or a very prolonged COVID is positively associated with having more than 2 infections. If you had COVID twice or more, you have a 32% higher chance that your long COVID is going to last more than a year compared to having just one infection. So let's not say I came down once, I can have another one. That's not true because it seems to be associated with higher risk. And of course, there are other important risk factors, being women living in high altitude have comorbidities. Here, comorbidities is an analysis that took us a long time because we know that having comorbidities is associated to have a higher risk of complications for COVID. But once you develop long COVID, we didn't find that having comorbidities, having low COVID was associated to a higher risk. So perhaps people who have long COVID and have hypertension, it's not that they have a higher risk of having long COVID than the one that doesn't have comorbidities. So this is interesting. It is associated to COVID and severity, but not with long COVID. But what we have found here in terms of risk. But of course, those who have more comorbidities are going to have higher risk of having prolonged COVID. I don't know if we concluded that almost half of those who had COVID in Ecuador reported some type of prolonged symptom, some type of sequelae. So more than 50%, 52% to be exact, have reported some type of symptom. I came down with COVID a month and a half ago, and believe me, I still have that fatigue lasting. This type of affliction is complicated, and for the fragmented health system of the Andean region is complicated because more expenses, more of a system that's broken in many countries. We are facing a new health problem, which are all these sequelae are going to require medical care of some type, either by buying drugs or going to the hospital. And to finish with my conclusion, the most common was fatigue, hair loss, and difficulty concentrating. And of course, the group that more reported was from 20 to 40 years. But once again, the limitation is because of the access to social networks. Residents of high altitudes have a positive association with a longer duration and with an very early onset. And of course, those people who had a history of infection or more than once had higher risk of having COVID-19 and long COVID. Well, thank you so much for your attention. I hope I didn't excess exceeded my time. I have TikTok. I have, if you have any questions, concerns, we can answer them in my social networks, and I always ready to answer your questions. Thank you so much for the invitation to the person who organized in the Andean Health Organization, and to all of you who have joined us. And thank you very much once again to you. And any questions that you have, we're here. Excellent presentation, Dr. Esteban Ortiz. Thank you. It's very important to highlight some topics that are important to keep in mind. Study that you carry out in Ecuador by your team was specifically to establish the magnitude of the long COVID process, and therefore they carry out a self-perception survey of symptoms that was massively included in social networks due to the limitations to do in-person survey, and you use mass media communication systems. Close to 25% of people who had post-COVID symptoms or sequelae had some comorbidity. Among the findings, the patients who had COVID-19 before vaccination had more symptoms, and after being vaccinated, the patients had less symptoms. This is important to consider. 70% of participants lived in high altitude and was associated to a better survival of severe COVID. So perhaps the adaptation to hypoxia could be one of the factors that prevented more severe forms, and this has been replicated in other studies in some other Andean countries with regards to COVID at high altitude. Something important that he highlighted is that there's a higher risk of long COVID if you have more number of COVID infections. If a person has been infected more than once, the likelihood of having long COVID increase. And this is important to highlight in the study. And close to 50% of people who had COVID in Ecuador had at least one symptom of long COVID. This is a very important study. It's important to highlight that it's a preprint and perhaps needs another similar study, but this evidence is important for the Andean countries in order to take the adequate and joint actions to respond to this problem. Thank you very much, dear doctor. We invite you to stay in the room. At the end, we will conduct a dialogue and respond to questions. Now, we invite Dr. Luis Hernandez. Luis Jorge Hernandez. He's a medical director specialized in epidemiology, master's degree and public health, doctor in public magister in bioethics. He's currently the director of research of the Universidad de los Andes in Bogota, Colombia. Dr. Hernandez has work experience in social security, the Health Ministry of Bogota, and the Pan American Health Organization as a consultant. His area of work and research on issues related to environment and health, public health programs, matters of care, social and environmental determinants, care governance, and health education. He is a member of the International Society for Environmental Epidemiology, the Colombian Association of Public Health, Association of Alumni of the Faculty of Medicine of the National University of Colombia, and the Alumni Association of the University of Los Andes Uniandinos. Go ahead, Doctor. Welcome. You have the floor. Thank you, Dr. Bengolea. Thank you, Dr. Mariel Carmen Calle. And to my colleagues, Dr. Eduardo Penny and Dr. Chris Ortiz. You have mentioned most of what I wanted to share and excellent presentations. I would like to complement with the experience of Bogota and Colombia with our long COVID through the observatory at the University of Los Andes. How frequent is this long COVID? It's been told both by Dr. Esteban and Dr. Eduardo that this is not a specific, this is has a variability of symptoms and signs. And this paper from Italy, that 87% of people were recovered and were discharged, show persistence of at least one symptom, even up to 60 days later. From these, 32% had one or two symptoms, while 55% had three or more. Fever or acute disease traits was not seen in these patients. Some symptoms in hospitalized people. We think that in Colombia, long COVID may be present or post-COVID between 1 and 2 million people. That would be the scenario for the next 2 or 3 years. That implies, and I'm going to present what can we do and how we have the health care system ready for this. We know that the infection by SARS-CoV-2, approximately 80% had mild or moderate disease, and among those with severe disease, 5% develop a critical disease, and a percentage of them present a long COVID. And there are several definitions for this long COVID to describe the presence of several symptoms that weeks or months after having COVID-19, regardless of the viral status. It's also called post-COVID syndrome that may be continuous, recurrent, or remitted. It can come and go. Symptoms may persist. There's a large variability of symptoms or the emergence of new symptoms. So this will imply us to a better definition of the case. Most of persons with post-COVID are PCR negative, which imply a microbiological recovery. But this is a time that's between the microbiological recovery and the clinical recovery. So one of the lines that Dr. Esteban is doing in terms of research is going to be very important. Most of people with long COVID show biochemical tests of recovery and radiological recovery. And depending on the duration of the long COVID system, we can divide it into stages. It is accepted by the Ministry of Health of Colombia. Acute post-COVID, where symptoms extend beyond 3 weeks but less than 12. And a chronic COVID, where the symptoms extend more than 12 weeks, more than 3 months. So those two definitions also mention the variability of symptoms. Been mentioned symptoms that are in a specific, that has already been shown: fatigue, headache,
leves, moderados y graves.
mild, moderate, and severe cognitive symptoms. 80% with at least one symptom. We see cognitive impairment even in children, and chronic fatigue, sleep disorders, digestive disorders, cardiovascular, neurological, pulmonary disorders, a large variety of symptoms. What's happened? What do we see in Colombia and in Bogota? Because some figures, this is the monitoring from the Ministry of Health of Bogota, working together with universities. To date, we took 1,200,000 people have recovered. So if we say that between 30 to 50% may have symptoms that are compatible with the case of long COVID, we could be talking that in Bogota of almost 200 to 300,000 people that have this condition, and almost 2 million people throughout the country. In Bogota, we've seen in 29,800 deaths, but there are differences in the different territories. Those differences in those territories is going to give us the clue for the interventions. This fifth peak in one of the Colombian regions is almost over. With this is the R is 0.46. This week, it was up to 3 in this third peak. Positiveness also decreased with active cases, and the most important predictor, the mortality, is with a decreased trend, which gives us to anticipate that in 3-4 weeks, we could talk about an endemic phase for COVID. However, we can see these waves, and we have the challenge of what happens with long COVID. Here I want to show chart. There is a territorial difference. More mortality in men, more morbidity in women. We also mentioned because the role of caregivers at home house level, and in Bogota, a concentration of the death towards the southeastern part of with a low, poor nutritional and socioeconomic status and air pollution. Bogota is at 2,600 meters above sea level, but this more intense red is in areas of impairment. All of the social classes have been affected, but there is a higher link with a low socioeconomic level. Here we show the most affected age groups are the young. This is a distribution in Bogota towards more cases of morbidity in women than in men, although more mortality in men. And this link to socioeconomic condition. And in this graph, we see the baseline diseases of the active cases. These baseline diseases in this graph is showing more towards all the age groups, but in young adults, 30 to 39 or more than 40, baseline diseases, arthritis, cancer, diabetes, asthma, chronic renal disease, hypertension, overweight, obesity, tuberculosis, HIV, AIDS, that put them a higher risk to have COVID and long COVID too. This is telling us that these people with baseline diseases or conditions have not been adequately detected, have not received proper treatment, and this is a failure of the health system. what the pandemic did was to evidence these inequalities, how this was more affected to the poor and vulnerable population, and in relation to comorbidities that are not diagnosed and properly treated, in which they're suffering the long COVID. Quarantines had a very negative effect because they didn't have access to health services, early diagnosis, and follow-up to people with cancer or chronic conditions, or conditions that decrease their immunological response. So in these histograms, we can see the elevated presence of baseline morbidities that is going to orient how we respond. So in the first conclusion that we arrived to was the need to visualize long COVID as a problem and a challenge to the public health that is not anticipated in our health plans. We need to make this visible, like Ecuador, with this survey that is a problem and is a public health challenge that has been invisible. In Colombia, in the red of services, this is a response with a diagnosis of COVID. There is a possibility to identify in the most vulnerable regions, such as the Pacific coast, the Atlantic coast, the border with Venezuela, which are 1,400 kilometers. Colombia has received almost 3 million of Venezuelan migrants. That implies a challenge for healthcare. At this moment, 15% are migrant deliveries in Bogota are of Venezuelan women that need to be treated in the health system, but this represents a challenge in this endemic scenario. Also in this area, in the Amazon area with Colombia, with the presence of armed groups and social instability, that also are a social challenge, of course. The response of health services to long COVID is quite limited. We're not doing any data collection. This map is with sexual and reproductive problems. The darker lines indicate, darker colors indicate what is lower coverage for reproductive and sexual programs. This serves as a proxy to long COVID, which requires specialized health services of multidisciplinary care. And we see that regions such as the Amazon, departments as Cauca, Huaupés, Huichala, Putumayo, Chocó, and then we have La Guajira, the border with Venezuela, offers challenges in health because they don't have an hour coverage of health services. So it is important that we need to do this training for those health workers. And this is Bogota. In Bogota, with almost 8 million inhabitants, we have a concentration of services toward the north part of Bogota, but we see that morbid mortality affects more the south part of Bogota. So there's an imbalance, asymmetry in the distribution of health services that may be being seen in other countries of the region. Coming now to the conclusions and recommendations in our observatory in Bogota, the need to establish the strategy to COVID and the pandemic and post-pandemic or the pandemic endemic, assuming that the pandemic is not over. And there we have two major types of strategies. We have, as the previous speakers mentioned, we need to prevent the person to get long COVID is to avoid them to come with COVID in first place, the strategy of vaccination. However, it has to do with the large models of interventions in the pandemic that at the international level too, the strategy for elimination, suppression, and the mitigation strategy accepted by most of our countries, Mexico, Colombia, Ecuador, Peru, a mitigation strategy to interventions to reduce cases of coronavirus and prevent collapse of health systems, compared to the other elimination and suppression strategy with a maximal effort to reduce spread, epidemiological intelligence, test, follow-up, isolation. This wasn't done adequately during the pandemic, and they decided for quarantine with a great social and health cost in our region. Countries that decided for elimination suppression strategy had a better response, like South Korea and Singapore, compared to those who decided and still use mitigation strategy. Now, what recommendations can we do for long COVID? Not enough to notify active cases and mortality. It's also important to report long COVID. It should be used in considered for the observatory and in the switchboard of the sanitary authorities. Visualize the event of long COVID, have the definition of suspected, probable, and confirmed cases, and to put them together, put them in the systems of epidemiological surveillance, train health personnel with physical rehabilitation, cardiovascular neurorehabilitation, also mental health care. It also implies to train competences in human talent to treat long COVID, and those competences are not yet visible or being organized. In research and translation of knowledge, this is quite representative of how to move ahead with the highlands and the relationship with the story, to orient public policy from the Ministry of Health of this region with the translation of knowledge, to have comprehensive care and interdisciplinary care clinics that collect several specialties knowledge, both in medicines and in other areas of health, like nurses, psychology, physical therapy, mental health, infectious diseases, and internal medicine branches that allow a rapid recovery and rehabilitation. We are lacking those services have not been considered, so we need to move that ahead in Colombia. In Colombia, we have 1 to 2 million cases that have this condition, and the next 2 or 3 years, we're going to see them. We also need to include in the health plans and primary healthcare health models to respond to long COVID. Primary ambulatory care, this is extremely important, giving preference to ambulatory household care. Our country have to rethink health models, and the long COVID is offering us that challenge to rethink and start with multidisciplinary ambulatory care. Let's not forget that we are, then it was mentioned, we have a syndemia. Syndemic, we need to improve the quality of life and the healthy environments. We have high prevalence of overweight, obesity. We are in Colombia, we're diagnosing 30% of diabetics and not 40% of people with hypertension. The pandemic established access barriers, and we are in the re-emergence of those chronic events. Many of them manifested as long COVID, but there's a re-emergence of a baseline that was silent for 2 years and that is manifesting it now. What implications with this? And we have presented this to the public health authorities about this endemic perspective. No to police or confinement or quarantine. No, forget about them. To decrease the socioeconomic and health vulnerability, women are more vulnerable. This is not just a health problem. The long COVID problem is not just health sector, it's from the entire society. Induce demand for elderly and patients with chronic conditions, promote physical activity, food security, have a 30% prevalence of adolescents in of obesity in adolescents, mental health, the high rates of suicide behaviors, anxieties, depression, post-traumatic stress, which are also manifestations. Air pollution is not being considered. It's key for the strategy. Forest fire, deforestation has increased in common borders. There's a loss of these ecosystems. Vaccine is just part of the solution. Of course, we need to vaccinate, but I also call on our governments to have comprehensive response, mostly in this scenario of long COVID. Thank you very much for your attention. Excellent, Dr. Luis Jorge Hernandez. You have closed this session presentations. It's an holistic analysis of the COVID and long COVID problems. One of the most important lessons is related that you have made an analysis of the vulnerability situation of the migrant population and also of the border spaces where more problems are concentrated, more vulnerability, more poverty. An important aspect in this strategy is to propose solutions that evidence the problems, and one of them is related to define a model that would allow the identification of long COVID from the clinical diagnosis that needs to be done in health services, to prepare health services and prepare the system to learn more about this long COVID and be able to know its real magnitude. The prognosis is that after the fifth wave in Colombia, they anticipate that in 2-3 years we could have these health problems in the population that has long COVID, and that is going to bring an overload in services, and the system has to be ready to tackle with that problem. You ask for research and call to do studies in this relation, and you put as an example what Ecuador has done with a population study that allow us to have an important piece of information to have a baseline and to learn in more detail this condition. Finally, call to the authorities to tackle this problem, this disease, not only from the health point of view, but also from the social and economic point of view, that other stakeholders participate to prevent injury and that having an overload in healthcare and more expenditure. Dr. Luis Jorge, thank you so much for your excellent presentation. And now I would like at this moment to tell you that at this moment we have a very special audience in different countries. Among the institutions that are present here, we have the Ministry of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. The Navy Medical Center of the Peruvian Navy, the Roundtable for Struggle Against the Poverty in Peru, Good Hope Hospital in Peru, Duke University, Leoncio Prado Hospital in Huamachuco, Pedro Ruiz Gallo National University, and the Health Office of Cincemejo. Countries that are present are Argentina, Bolivia, Chile, Colombia, Cuba, Ecuador, Mexico, Peru, Venezuela, Dominican Republic, and the US. To all of them, our thanks for your interest by attending this meeting with important topics for public health. After the active break, we will have a dialogue in response to questions from the participants. After these moments of learning and exchange of knowledge, it is essential to take space of your time to relax and start a mini session of physical exercise during telework. Our institution encourages the well-being of those who accompany us in this virtual session. And in this next few minutes, we will exercise with an active pulse to stay healthy, combat stress, reduce work fatigue, and keep our muscles flexible and healthy. Please go ahead with this active pulse. There will be no interpretation during this active pulse. We will come back for the Q&A session.
Pausa activa.
Buenos días, buenas tardes, desde donde quieras que te encuentres en cualquier parte del mundo. Desde el Organismo Andino de Salud Convenio Hipólito Unanue estamos muy felices de recibirlos en esta actividad saludable. Hoy bienvenidos a liberar las tensiones acumuladas en la espalda y en los hombros y solamente utilizaremos nuestras sillas. Así que vamos a arrancar calentando de una vez. Quiero que te imagines en una piscina y que estás nadando hacia el frente, nadie hacia el frente, perfecto. El que no nade se hunde, perfecto, ánimo, energía. Eso es, vamos. Calentando los brazos, los hombros para liberar las tensiones de la espalda. Bueno, sabe que nadie hacia atrás, vamos, energía positiva. Brazos amplios, grandes, generosos, excelente. Bueno, y el que se descoordine gasta algo. Con el brazo derecho nado al frente, con el izquierdo nado hacia atrás, caliénteme los brazos, perfecto. ¿Cómo están? En una piscina en Bolivia, en Chile, en Colombia, en Ecuador, en Perú, en Venezuela. Excelente, liberando estrés, cambie. Entonces, brazo contrario adelante, izquierdo adelante, derecho hacia atrás. Si se puede, domínelo, caliente la espalda, los brazos, los hombros. Muy bien, y descanso, muy bien. Segundo ejercicio rápido de calentamiento. Quiero que nos aprendamos dos posiciones. Primera posición, manos a la cintura, llevas atrás, los codos, pecho adelante. Muy bien, mira hacia arriba, muy bien. Pelvis hacia atrás, perfecto. Estira un poquito hacia el frente. Posición 2, justamente la contraria. Bajas la mirada, brazos adelante, pecho hacia adentro, espalda flexionada y vamos a llevar la cadera, la pelvis hacia adelante, miro hacia abajo. Esa va a ser la posición número 2. Cambio, mira arriba, perfecto. Cambio abajo, cambio arriba, perfecto. Cambio abajo y cambie periódicamente. Mover la columna vertebral es algo 100% saludable para aliviar tensiones en la espalda. Perfecto, 3 más de esos, 2 más de esos. Último. Y descanse, muy bien, excelente, ya hay calorcito, así que vamos a hacer 2-3 posturas para soltar tensiones de la espalda. La primera, quiero que te ubiques al lado de tu silla, al ladito de tu silla, separa las piernas, muy bien, vas a apoyar la mano más cerca de la silla, en ella, la otra mano, bien arriba, pégala a las orejas, muy bien, cuando las tengas allí, mira, esa mano va a ir a buscar el otro extremo de la silla, va, búsquelo, agarre ese extremo de la silla, sonría, respire y vas a sentir la tensión, la liberación en la espalda, parte lateral, zona lumbar, eso es, respire, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, regreso y me estiro, wow, como que se siente, perfecto. Pero vamos a hacer el contrario, entonces me voy a ubicar al otro lado de mi silla. Recuerda que el brazo más cercano lo apoyo en la silla, separo las piernas, muy bien. Brazo contrario arriba, péguelo a la oreja y voy al lado, y trate de apoyar esta otra mano en la silla, si se puede. Maneja la respiración profunda, continua, desde casa, desde la oficina, Desde donde te encuentres puedes hacer estos ejercicios que traemos desde el Organismo Andino de Salud, Convenio Hipólito Unanue. Vamos, vamos, vamos. Regreso, regreso, regreso. Me estiro, me estiro, me estiro. Perfecto, excelente. ¿Cómo vamos hasta aquí? ¿Bien o no? Excelente. Vamos a darle la espalda a nuestra silla y vamos a poner nuestras manos, vamos a apoyar las manos en la silla, vamos a llevar el pecho adelante, mirada hacia arriba, estiro, estiro, estiro y empiezo a liberar ese cansancio físico, mental, emocional, todo lo que nos afecta en nuestra vida a través de la actividad física, los estiramientos, el salir de la rutina. Tomo aire, exhalo y descanso. Hombros adelante, crocanticos, crujientes. Muy bien, excelente. Siguiente postura, súper recomendado para las tensiones de la espalda. Así que acompañen. Vamos a apoyar las dos manos en nuestro asiento. Muy bien, separo las piernas. Quiero que estires las piernas y mira, llevas la silla hacia adelante o tu cadera hacia atrás. Y vamos a empezar a bajar. Baje, 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 cadera hacia atrás, apoyo. Muy bien, y voy a tratar de alinear mi espalda con el espaldar de la silla. Voy a sentir ese estiramiento, mire, desde las piernas, zona lumbar, espalda, brazos, estírese. Y ahí nos vamos a quedar 20 segunditos. Así que respire, eso es energía positiva. 10, 9, 8, 7, si se puede, 6, 5, 4, 3, 2, tomo aire, 1 y muy despacio me regreso, y ay, como que se va sintiendo la distensión en la espalda. Eso es, desde horas como y trayendo estos ejercicios para sentirnos bien. Bueno, vamos a repetir ese ejercicio y le vamos a hacer una variante, ¿listo? Bueno, apoya las manos en tu silla, llevas al frente, te apoyas, te estiras. Perfecto, cuando estés allí, quiero que subas un brazo, mire, y vas a mirar ese brazo arriba, se estira. Mi otra mano está bien apoyada en el asiento, manejo la respiración, profunda, continua, regreso y vamos a ir al lado contrario, entonces subes brazo contrario, arriba, te estiras, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, apoya las dos manos, perfecto, regresas en cámara lenta, regreso, ay, descansa. Se vale despeinarse, se vale todo, la pausa activa del día de hoy. Desde el Horas Como estamos muy felices de traerles estas pausas activas diferentes, divertidas, dinámicas y que favorezcan nuestro estado de salud. Así que los animamos a seguirlas realizando. Un abrazo fraternal, los queremos mucho. Chao, chao.
Magnífico ejercicio.
Wonderful exercise.
Las articulaciones ya no suenan como...
Our joints don't sound like before. Now they have some cracks.
Esperemos que hayan gozado de este
Let's hope that you have enjoyed this
saludable.
active pulse video.
Ahora vienen las preguntas.
Now we have the Q&A.
Nuestro público ha hecho realmente
Our audience have sent a significant number of questions
quisiéramos pedirle, por favor,
we would like to ask
den respuesta.
to give us an answer.
Eduardo Peña.
To Dr. Eduardo
La
Penny.
pregunta es,
Question is,
¿sería necesario realizar
do we need
exámenes de rayos
to
X en
take
pacientes
X-ray images
con COVID?
in patients who had COVID-19
Es una pregunta.
acute or
La segunda
mild?
pregunta,
And the second
¿qué
question,
indicación se debe de dar
what should you
post-COVID presenta síntomas
name the patient
intermitentes?
who had COVID and presents
¿Qué exámenes
intermittent symptoms for more than 3 months? What
Adelante, doctor
tests should be
Esteban.
performed on this patient?
Por las preguntas.
Thank you for the question.
Yo creo que el marcador
I think that the marker of the need
gráfico,
of a
gráfico de
CAT scan or an X-ray
pulmón por la
of lungs
saturación de oxígeno.
It's given by the oxygen saturation. If your oxygen saturation is decreased, I think that that's a precise indication that needs to be evaluated. And why? Because pulmonary symptoms that we usually detect with the stethoscope has been evaluated. Even though it is helpful, it is not necessarily adequate in every case. So if you have a patient with a saturation within normal limits and doesn't have any respiratory symptoms, I don't think there's a need for these exams. Of course, we always need to go the patient-centered medicine, and every decision has to be personalized. But in general terms, the response is like a normal saturation without respiratory symptoms. There's no need for this test. But the opposite, yes, I think it is important. In our ultrasound and chest X-ray, may be important to discover acute pathology. Of course, the gold standard is the CAT scan, but we have a problem of cost and sometimes they don't have the equipment available. The second question for those patients who had intermittent symptoms. I will say that here, that is why at some point of my presentation, I said, you need a very well taken clinical history with COVID in order to make a progressive evaluation of the presentation of symptoms, and at the doctor's judgment, evaluated if it's has value or not. But those patients who have more than 3 months with intermittent symptoms are considered also as long COVID. That they have it or not is a different story, but they should be considered as they have a long COVID and should be under evaluation. If at the start they didn't present any symptom and no chest X-ray was taken, and the patient starts having cough or decreasing after 3 months, I'm talking, the decrease in oxygen saturation, yes, it has to be evaluated as any patient with a respiratory condition that has a persistent cough. Now, it's always, these decisions always have to be personalized. Very kindly, Dr. Eduardo, to Dr. Esteban, in relation to the results of the study and the existing conditions such as a lack of electronic clinical records, what public policies would you recommend to be implemented in Ecuador? And the second question, what additional studies would help to improve the understanding of the pathophysiological effects of SARS-CoV-2? Go ahead, doctor. Well, thank you very much. Let's see. Public policy has to go together with the needs. Let's remember that now we are looking at COVID-19, but many other forgotten diseases, emerging and re-emerging diseases that need care. So in order to approach this, epidemiological surveillance and health promotion are important. We take some of the vector control programs from other pathologies. Now, with regards to COVID-19 and long COVID as a country, well, first is to collect information. In our countries, we have a fragmented system. We have the public universal system, we have a private system, and it's not connected to the public sector. We have social security that is also disconnected from the public sector, and that information is lost. Social security has its own data, but doesn't do any epidemiological surveillance or follow-up. The Ministry of Health receives data from the ambulatory outpatient service only of the public system units, which are the largest and are not all of them. So use technology for collecting information to have updated information in terms of patients that may be identified as under risk of developing COVID and do an adequate follow-up. On the other hand, we have difficult times in the Latin American politics, and misleading messages come from privatizing certain areas of health. So I think that the messages have to go together. We need to reinforce public health. The pandemic has shown that promotion of health comes with better economic indicators. So to control long COVID, in addition to what has been mentioned, the first thing that we did was the most simple thing, and perhaps the less level of evidence. Ask people what complaints they have, and from there, we will have to analyze and corroborate with statistical data of the new admissions to hospital and the new outpatient, what is people being treated, and link this to other socioeconomic factors. The issue, if we have scattered databases of different things, for example, our patients, we don't know something as simple as if the patient smoked or didn't smoke, or the patient drank alcohol or not. We need to do an absolute change of the digital platform for collecting data from the point of view that are useful to generate information. We need to plan in terms of the health systems, the impact and burden of disease by long COVID, because we do have the evidence that this long COVID is prolonged and increasing the demand for care and the risk of dying, the risk of getting ill, the consumption of medications are higher. We are going to a study about the unnecessary expenditure of medication during the pandemic. So I think that we will be more effective in terms of allocating resources and do an intelligent allocation for the control of long COVID. Now, what can we do? What was it? What other studies will help to improve this standing? Well, let's see. We know that we always live in the shadow of what hegemonic countries do in terms of research on COVID has already been studied in other areas. I think that the local regional information from our own perspective is very important. I would suggest to do the same analysis from the point of view of including other population groups that we were not able to include, with having a quick access to data, vulnerable populations, indigenous groups that still have many problems from the health point of view. So we can include vulnerable groups and follow up these patients. I like what Luis mentioned about the state and government support that we can give to those families that in some cases have lost loved ones. COVID killed many people. Just in Ecuador, more than 90,000 people died directly from COVID. And all those families are affected from the socioeconomic aspect. And if you add an additional disease with fatigue that they cannot work, headaches, they ask for home leave. So there are many things to do, and with everything that's been said in this space, is precisely to collect information. So I think that today I could suggest as a take-home message is that we have to improve the quality of information and recollection of information so we can have accurate data with regard to our populations that are different. And finally, making echo of the word of the other speakers, the mobile migrant population, we at some point described at the start of the pandemic about the vulnerability of current Latin America in terms of COVID-19. It was in April of 2020. I wrote an editorial for the Lancet, and it was not accepted, or it was accepted in the BMG in an opinion section. But months later, they issue a very similar editorial from Anglo-Saxon authors. We have a reality that is not living in other areas. We need to take care of that migrant population that includes children, elderly women, and another group of vulnerable populations. So we need to focus on them. That in this case, the long COVID will be one of the many problems that they suffer, but perhaps it's going to be one more. And this is what I always say. It's not just one new disease that is not killing no one anymore, but that it's a new disease that you take in your backpack which is the burden of disease that a country has to suffer, we're putting 4 blocks of 1 kilo each. That backpack becomes heavier and more expensive. So we need to pay attention to that. And of course, we need to focus in preventing and once again the spread and the most efficacious way to do it. And that's the brainstorm. Thank you for the question, Doctor. Thank you, Dr. Ortiz. For Dr. Luis Jorge Hernandez, many countries have eliminated or towards to eliminate several non-pharmacological measures to prevent spread, a situation that exposes people more to the development of long COVID. What actions could be of priority? First question. The second question, what opportunities are in Colombia and other Andean countries to develop organized multidisciplinary teams for long COVID care? What countries have made progress in that, and what can we learn from their experience? I think it's important, with related to the first question, we need to relax those measures. There's a lot of fear. People are still using mouth masks. You need to vaccine. The fourth dose, and Dr. Luis told us at the beginning, of course you need to be vaccinated, and have the Ministry of Health authorizing the fourth dose to less than the age of 50. We have the vaccines, but they are not adequately being applied. And we need to add COVID to a regular vaccination. And I'm talking about polio, for example. We need to add COVID because the vaccination is to continue. It's a seasonal vaccination. Number two, use mouth mask in public transportation, not in open spaces. Have a good ventilation, wash your hands. These are the measures that must stay. Ventilation, washing hand, face mask in the bus, in the public transportation. It is not required in the classroom. Someone has respiratory symptoms, use the mask. But it's no need for that. And number two, I think that this initiative of the Andean Health Organization is extremely important to share experiences, what other countries have done. We need the patients, citizens, the academic work with the health authorities to include this in health plans. Universities, my colleagues from my university are teachers, and in our universities, our health students should know about long COVID. The health services should have training. We cannot afford that the pandemic is over and nothing happened. We need to learn the lessons. We have a depth with undiagnosed patients that were not followed, with malnourished people, with very vulnerable socioeconomic conditions. That lesson needs to be learned, and we should put pressure on our government. And this initiative that this agreement is doing to visualize experiences, to have a second chance and evaluate what is being done with concrete proposals of response in models of healthcare facing the long COVID. Thank you. Thank you. A question for all of you. Long COVID refers to symptoms after the infection by SARS-CoV-2, and persistent COVID is the presence of the virus in the body after the acute phase. This short explanation is correct. I will repeat it. For the long COVID has to do with symptoms after the infection due to SARS-CoV-2, and persistent COVID is the presence of the virus in the body after the acute phase. Is this explanation correct? Go ahead, Eduardo. Actually, the answer is no. It's partially true. the symptoms after an acute infection, when you can establish it, are called persistent COVID or long COVID. But, and this is one of the things that I mentioned, there is not an agreement on what is the time established to call it as such. Most of countries use the 4-week mark, but there are countries that use 3 months, 6 months, and that is one of the problems that we need to take into consideration. The other question was if there was persistence of the virus. Well, in patients with long COVID, it has been shown, as I show you, up to 50% of them, that they was able to detect active viral residues in plasma. That is 50%. What happens with the other 50%? That is why we cannot assure it's 100%, because it's only been shown in half of the patients. So although there may be a instance of the virus in those patients that have not been proven, yes, in one half of them, and in those that it has been investigated. When you do investigation, sometimes you select a group of patients, and the numbers may be higher to what you see in the real world. Thank you. Go ahead, Dr. Esteban, for the same question. Well, I can add different comment to those from Dr. Penny. I know that we have to recognize from the point of view of country or a health authority, recognizing that despite that we have large deficiencies, we need to recognize long COVID as a new pathology. We have to record it and give the importance it deserves. And with that, we can start proposing public policies. From Ecuador, speaking from the Maximal Health Authority, they don't talk about long COVID. It's not being promoted. There's no programs. There's nothing around this issue. So starting there, recognizing that long COVID exists, that this is a serious health problem that's going to stay here for a long time, and the definition, if it's 3 weeks, 4 weeks, we will have to finally start defining it locally or based on the evidence of 4 months, 2 months in the post-acute stage, because the post-acute symptom is one. People have symptoms 2 weeks later, but apparently most of them decreases in a significant percentage, so we need to wait, or we have to start generating our own guidelines. Why not? Latin America has been leader in many infectious diseases that as a regional group, being able to control, do something similar in terms of long COVID. It were more patients we had, more death we had, so we will have more patients with prolonged COVID, so perhaps have that responsibility. Thank you, Dr. Luis Jorge. Yes, I would just mention that let's remember that definitions in epidemiology are syndrome, are very sensitive. They capture everything. So that could be the agreement or the organization to unify these concepts. And number two, there are people that are going to have a positive PCR. We've seen that with President Biden. People who were positive and they were isolated and over. We cannot depend on lab tests. We cannot be dependent. Some people are only going to have a positive test. We don't know why. But if they have respiratory symptoms, that's a different story. You have to believe more in the symptoms, quarantine or face mask. You establish your protection measure. That's more important and not depend only on tests. The specificity and sensitivity are different. And in Bogota, we will have 4 or 5 people who are positive and they don't need to isolate. Use face mask, yes. If symptoms are present, the test is just for epidemiological topic. And well, and the final question for you three, are there drugs to treat long COVID? On the other hand, there are cases where health professionals prescribe the use of ivermectin. What do you think about this practice? Go ahead. Well, first of all, when we talk about analysis, we don't refer to the detection by PCR in saliva. We're talking about viral residues in plasma, 54%. That's the study that I mentioned. The first question was, do you have drugs to treat long COVID? No. At this moment, there is nothing to treat. There's a lot of research, and therefore the importance that study that I showed, because if you show persistence of the virus in plasma, that's telling us that the virus is active in the body. And that opens the possibility to study a number of drugs for long COVID. I'm not talking about the drugs for acute COVID. That's another topic that should not lead to confusion. And the second question was about ivermectin. This is something that I will say very controversial, and apparently it's no longer the case. There have been many people that has stimulated the use of ivermectin with very little scientific evidence, with very few well-done studies. And that's the problem. It has been used massively, and in our country, in an area where they stimulate, where the mayor was distributing ivermectin for free to everyone who asked, was one of the areas of the country where more COVID was present. And there was another controversial study, and that is the issue. It is not, we don't have to study just to study. When we do research, we have to do a good investigation, not with many cases, but with a good study design, because otherwise the conclusions may lead to worse mistakes. Nowadays, despite all the evidence, there's still physicians that are prescribing ivermectin and recommend it. I particularly don't do it and haven't done it because, in my judgment, there's never been a real strong evidence that this was useful. Fortunately, we've spoken about a drug with a low toxicity in adequate dose, fortunately. Otherwise, we will be crying for more deaths, especially in those cases where it was applied intravenously, or when they use ivermectin for animal use. But there's no justification for ivermectin. Thank you, Dr. Eduardo. Esteban, go ahead. Well, in relationship to the treatment of prolonged COVID, there is no treatment. It depends on symptoms. The very rare symptoms such as pain and that burning sensation will have to be treated with some tricyclic antidepressant. We'll have to symptom to treat the complaint. That in general, long COVID is everything. Now, from the point of view of the drugs in this study, the growth of cells of ivermectin in Ecuador and hydroxychloroquine, and I have to be very emphatic here. In Ecuador, a mayor gave out 2 million doses of ivermectin, and the current evidence doesn't serve to treat COVID and should be stopped being used. It's completely useless, and it could be a case of malpractice if a physician prescribes ivermectin. We found in this study, fortunately, we didn't find a positive association with mortality, but hydroxychloroquine, as you can see, how much hydrochlorine was sold in Ecuador, we saw of correlation with mortality. So my final message, because I have to leave and I thank you, is that one, ivermectin, it's clear that the scientific evidence says it's useless for COVID. We should stop saying these things. And second, a final message is that we need to make people understand that a viral disease is usually self-limited, except very rare cases such as HIV. I remember when people talk, I cure with chloride dioxide, and I show the slide that I cure myself by eating ceviche, because at the end, everybody gets cured or the disease is self-limited. So the message needs to be clear. Viral disease, self-limited, that requires symptomatic treatment in most people. Yes, perhaps ibuprofen, paracetamol, or some, and that's it. Anti-flu medicine, perhaps. From the ivermectin point of view, as usual in Latin America, we're sometimes a negative example of what doesn't need to be done. That misinformation and politics have made them to be promoted, given away for the use of ivermectin. Ivermectin sales double in 1 year, $9 million. I don't know how important was that, but if $12 million was invested in diagnostic tests, we will have less death by COVID-19. Thank you to all of you. Unfortunately, I have to run out. I have another meeting, but thank you very much. I'm going to try to connect with my cell phone to hear Dr. Hernandez. Thank you very much for your invitation. Thank you, Dr. Esteban. Thank you. Go ahead, Dr. But Dr. Eduardo and Dr. Esteban is clear. Ivermectin is useless. Just recommendation, people, don't believe in so fake news. Believe in these events, such as talk to your health authority. Look for people that are credible, because there are many things that are not true. Look for good information. Thank you. We thank for the questions. We weren't able to respond all of them, but we will take it into consideration to define the topics of the next webinars. We thank you for your participation. To close this space, I ask the speakers to, in 1 minute, leave us a final message. Go ahead, Dr. Penny. Thank you, Luis. There's been a terrible lack of leadership in this pandemic. Both from WHO and the Pan American Health Organization, the ministries of health, the regions, health regions, have let everything happen. They haven't put any order, although we are facing a theoretically new disease. We didn't learn anything on the first 20 years of this millennium, where we had problems with other SARS, with the porcine virus, where there was even problems afterwards that we haven't learned. Therefore, it's something we need to get in this pandemic, is to put our health aspects put in order and become leaders with a good clinical record, an adequate treatment and follow-up, etc., etc. We don't do this, we haven't learned anything from this pandemic. That's my final comment. Thank you, Luis. Go ahead, Dr. Luis Jorge. Yes, I agree with what Dr. Eduardo has mentioned. I'm optimistic. I think that we have health services with technical teams and universities that give us some lessons, that it is up to the citizens to continue to improve health services, to improve the quality of life of children, women in our region, for early detection of events, treat them. This recover public health of our countries. And this is our responsibility, and it's key that the citizens learn about that. We cannot be passive. We need governance and follow-up by the citizens, the university, the patients' organizations, and these spaces offered from this during Andean Health Organization through the pandemic has spread knowledge. And I said at the beginning that people believe in these spaces of high quality. Thank you. And I think that this is part of the path we need to follow. Thank you. Thank you. We are deeply thankful to Dr. Eduardo Penny and to you, Dr. Luis Jorge Hernandez, and to all those of you who week after week follow us, to the Andean Health Organization team, and to all of you who participate in this activity, which has been possible thanks to the commitment to Andean and Latin American integration. I will now give the floor to close this webinar to Dr. María del Carmen Calle, Executive Secretary of the Andean Health Organization. Go ahead, Dr. Calle. My first words to thank Eduardo, Luis, Esteban for your participation. You mentioned very interesting things that are going to allow us to continue working. I would like to mention that the Andean Health Organization doesn't organize webinars only. We have technical meetings with the 6 representatives of the countries, and everything that we learn or that we know ends up in something concrete. I don't agree that there hasn't been any leadership. I don't agree with that, Eduardo. That is a personal position. I am working from April of 2020, and I've witnessed an exceptional witness of all the effort being done on the 6 Ministry of Health, which I coordinate with, which are Chile, Colombia, Bolivia, Ecuador, Peru, and Venezuela. Whether we could have done things better, of course, definitely. That we should integrate in more things, of course, definitely. That there was at some moment lack of leadership, yes, definitely. But that has been a chronic of an announced death. Our countries have fragmented health systems, non-inclusive, and doesn't have the quality standards that other systems can have. However, the pandemic has been a world catastrophe. Not only our countries have suffered. We recognize that our countries are among the countries that more death in have had. There's no doubt about that. However, we also need to recognize that there must be an integration and sovereignty in terms of health. I am referring that we can continue depending from other countries to make diagnosis. We cannot continue to depend on other countries for personal protecting equipment, for ventilators, for vaccines. At this moment, we see that with the monkeypox, all the production has been purchased by the countries of the north. So there is no doubt that COVID, the long COVID, although the exact definition still not present, as Eduardo mentioned, there are several definitions for weeks, 3 months, but the thing is, concrete, long COVID is a public health problem, and we're going to see it in the burden of disability that perhaps we're going to measure in 2 or 3 years. Dr. Luis Jorge talks about 1 to 2 million of people that have this condition. In Peru, I guess that should have similar figures. Let's remember that Colombia has 15 million people, Peru has 33 million. I consider that all this information that we are receiving, and we deeply thank, we have been discussing with Lucho, it will generate a technical meeting with the decision makers from the 6 ministries, and we have monthly meetings. Once a month, we meet with the high officials from the countries. Our countries are very special. In recent months, we have government changes. We need to adapt to those changes. But in the meetings with national health authorities, we talk about important topics where we can work with the 6th country. Definitely, this long COVID, and that's the reason why you've been invited to the webinar, is one of the topics that are going to be considered for the next meeting of National Health Authority. Before that, we will have the meetings with experts and the representatives of the ministries of health that are actually the ones who make decisions. I'm sure that we have to action. And one of the most important things that we need to consider is to start from the start, to recognize that there is a long COVID, start collecting information, and of course, start with no budget, there's no rights. So we need to start to think in our national budgets. It should be considered also in what we will call prolonged diseases, chronic diseases. Because we always mentioned that chronic diseases are non-transmissible, but now we realize that there are chronic diseases that are a result of an infection. Thank you once again for your presence. Been so good to get an update of what's happening in our countries and to continue working. I thank the academic. The academic will always updated with all the information. Thank you very much. I invite you to the next webinar of tonight. Tonight at 7:30, we are working with the Rotary International District 4455 with the Ministry of Health, and the topic is Vaccinate Peru. We're going to talk about the situation of immunizations because the speakers already mentioned we have left behind in coverage of diseases, and we have measles in 4 countries in South America. There's an increase in whooping cough. Well, I'm not going to continue everything, but we need to talk about that tonight at 7:30. The next Tuesday, 23 at 9 a.m., Yadira, we are presenting the Health and Economy Forum because health has to do with the economy and economy has to do with health. So next Tuesday, August 23 at 9 a.m., we will be presenting this Forum of Health and Economy with the sub-regional program from the Pan American Health Organization. We're going to have experts from PAHO, Fiocruz, that will talk about this important topic. Thank you so much. Good afternoon. See you soon.